All right, we are recording. All right, so welcome everyone, welcome colleagues. It's wonderful to spend this time with all of you. So this is the second session of Trauma Informs Love. As I already mentioned during our previous first series of the lecture, this is a topic that is very close to my heart and also something that I have had many real world experiences, my own experiences, and also having worked with lots of clients in this evolving field. I'm very excited to co-create this space with you and continue this journey. So as we begin, I see that many of you are joining. Welcome, welcome. Great to have. I'm Fernando Hetiadra. I believe many of you know me well. So we will dive into this session. And our focus here, as you have already noticed when we created the very first engagement, we are not looking at trauma as a victim or a prosecutor. Very often when we approach difficult, challenging experience, it's quite natural that we might feel like these difficult experiences are bad or negative. However, here our focus isn't either we are persecuting trauma or neither we are becoming the victim of trauma. We rather really look at how trauma truly informs love. So this exploration is for us to enhance our relationships and also understand deeply about ourselves and create transformation within ourselves. So may I invite all of you to keep your microphones muted as this is the lecture. And then, of course, if you have any questions, feel free to put them in the chat room. And if I need further information from you, I will invite you to open your microphone and speak to us. One of the reasons why I can't really put you into mute is because the Zoom is a little bit slow today for some reason. So maybe it's my internet connection. So let's continue in. So today's topic is how the unconscious whispers from the past quietly hold us back from our fullest life, fullest potential. So we are really focusing on these whispers. The whispers. What do I mean by unconscious whispers? So this is really about how we operate in the world without our own awareness, how sometimes we have certain challenges, difficulties, and how we sometimes are unaware about our own way of experiencing, sensing, feeling, behaving, and so on. So in order for us to do that, since we are talking about the unconscious whispers from the past, it's very important we also gain a good understanding about what from past whispers in our ear at a later time. So I'm just coming out of a group mentor, ICF group mentoring session, and the session was very interesting because the client who took the role of the client was exploring about imposter syndrome. And what was really interesting is that the client kept on saying that there's something not known, there's something not tangible, there's something I really don't know. And it was very sincere in that conversation. So then we understood during that session, maybe certain things that the client isn't unaware, may be unconscious. The client isn't able to make it from unconscious to conscious. So there are ways of doing that, especially through psychotherapy, but also coaching can also do a great deal, enable clients to bring unconscious to conscious. So this is what we're talking about today. We are trying to look at what from past can impact us and
I
what are
don't think
these
you can
whispers that
as
we
a
may.
viewer.
Yeah. Do you hear me,
Okay.
Kali? Yeah.
Now you have to ask them.
Okay. All right. I made everyone muted. I understand. All right. So let's continue on. Yeah. So again, as you are aware, we're talking about trauma. So there will be talks around adversities, trauma, and similar mental conditions. And I will also share lots of examples. So if you are a sensitive person, please engage with this content with caution. Continuing on, I would also like to invite you to raise your hand if there's something really burning that you would like to ask about. At the same time, I would please send all your inquiry. They are all very welcome. At the same time, I will try and address what is most relevant to this discussion. In the future, we will be addressing depending on where your inquiry is most necessary. So for an example, last session, Julian asked us how trauma is stored in our fascia, specifically in our tissues of our body. And I did not answer it at the time, and I'm not going to discuss that today either. But in our next session, the third session, this is going to be our focus. So you will receive that answer very clearly. And then there were also a few other colleagues who were asking a few questions. I will make some notes as we continue into the journey, right? So if you're sharing anything, please keep it really concise so that way we can maximize this time. And as you're aware, the sessions will be available to you through Awaken Mind Guide. Feel free to access them. So I'm going to do a very quick recap for us to kind of eliminate those neural networks we lit up during our previous lecture, so that you will be able to bring some of those insights. I know that some of you might not have been able to do a recap, as I understand that many of you are occupied professionals, right? So you may recall that when we looked at this interesting, almost which appears to be a little bit funny, as we explored this, we came to understand that this cat's involuntary muscle reflex trying to get itself to safety from the shape like a snake is not just an adversity that was passed on to the cat through the generations who have experienced the venom of the snakes and who survived. It's truly an act of love when the intelligence in our body decided to send this information. The shape of the cucumber can be potentially a harmful reptile. Therefore, the cat's real function of having this reflection, the reflex in our body is to get ourselves to safety. So you see, although the traumatic experience was really difficult, this specific experience is passed on not because the evolutionary process, the higher intelligence in our body to hurt the offsprings of the cat, rather to truly safeguard the cat. And it's the same thing that we understood when we also looked at what happened in the survivor, the children of the survivors, we know, of the Holocaust, right? We noticed that the children of the survivors of the Holocaust, once when there was some kind of a shock and overwhelm, um, usually after a specific period of time, the body comes back to baseline. The body comes back to a regulated state. But we noticed the Holocaust, children of the Holocaust survivors did not necessarily come back to baseline within what we have observed as um, the general tendency. The reason is because of the adversities and atrocious trauma that their parents were exposed to, this natural intelligence in the body wanted to keep the children alert longer, the second generation in this case, and even further generations longer, all alert longer, because in case if there was danger in the environment, hoping that they will be able to get to safety. So we are starting to recognize once again that it is not the traumatic experiences and then the aftermath of it is not the difficulties, right? The challenges that we experience after is not necessarily something that is bad. We understand it is difficult. It's difficult, but it's not necessarily need to be a bad or a negative experience as such. What it's trying to do is really to safeguard us. So you see that the aftermath of trauma is most of the time is a way of coping, is a way of safeguarding us rather than wanting to break us. So we keep in mind, trauma informs love. The cat's offsprings, without cat's awareness, a deeper unconscious intelligence wanted to inform the love that is going to be uh, handed over to the offsprings. So trauma informs love. And then we also looked at causes of trauma very briefly. And what we come to learn is that too much, too fast, too soon, which is overwhelming experiences, happen very quickly, like an accident or maybe an assault or something like that, happen very quickly or too soon. It happened to us before the right developmental time, the developmental age. So that is what we consider as overwhelming experiences, too much, too fast, too soon. And then another side of trauma that we usually do not talk much about is not receiving enough. So a type of deprivation or experiencing a specific specific experience over a long period of time, not enough for too long. Like for an example, when a child grows up, we looked at some examples around attachment styles. If you recall from last week, the last session, we noticed that when a child was not provided with the primary caregivers nurturing and care during the first early ages of the child, they would develop certain behaviors and they would directly affect how they form relationships. As you're aware, relationships are absolutely important to us. You know that if you look at the Maslow's hierarchy of needs, you notice that we have several layers starting from the physiological needs, and then our security needs, and then that we have love and belonging needs, right? And then we have our self-actualization needs and fulfillments and things like that. But you know that love and belonging is one of the key areas, so that not receiving love and belonging as a child can affect a child directly. And you notice that it's not that parents purposely did something at once too fast, right? They didn't do what they're supposed to do, or whatever the reasons. So therefore, there was a deprivation, and that affected the child, and not just as a child, but also as an adult. So we looked at different definitions of trauma last session, DSM-5, then we looked at ICD-11. So if some of these things that I'm sharing with you right now is a little bit too fast, or if you didn't attend the previous session, I highly recommend you to go back and watch the session. The recording is already available, and also the slides are available. You can download them. All right, so we thought let's create a comprehensive definition for trauma for us to ground ourselves. So what we understood is that ex either an experience or ongoing condition either overwhelm the person or depriving something that is needed exceeds a person's nervous system's capacity to cope. uh, we are not able to, our nervous system is not able to cope. So when that happens, we are unable to feel safe, supported, or regulated. And also, our body and mind adapt in ways that prioritize survival over growth. And this is what, at least I understand as trauma. And if you have some ideas, feel free to send them in the chat. All right, let's continue on. So as I mentioned during last session, the more I listen to professional coaches and the more I continue my journey learning about trauma, I'm realizing how valuable it could be to have a comprehensive trauma-informed coaching competency framework that we all can be aware of and then also potentially use in our coaching. Not in any way we are trying to cross a clinical boundary in any way, rather to be aware, because sometimes not being aware could harm our clients. So it's really very important. And also beyond that, just because one of your clients has experienced some trauma, it doesn't necessarily mean that you can't coach the person. In fact, you might even be able to help the client help the client with acute regulation, maybe enable the client to create certain strategies to process their trauma, provided that they are receiving clinical care if it is necessary. So that means sometimes if the client's trauma responses, so the challenges are not severe, you may be able to assist the client in certain way without crossing clinical boundaries. In case if the client's situation is either functioning or impaired, we still can work with the client with the approval of a clinician who might be treating them. Could be a psychotherapist, psychologist, and psychiatrist. All right, so let's continue on. So speaking of this comprehensive framework, which we call CTICC from now, Comprehensive Trauma Informed Coaching Competency Framework, CTICC. I wanted to create it in a way that we can standardize this. So what I did was I resorted to ICF core competency framework, considering ICF is the golden standard for coaching, and many of you are ICF professional coaches. Doesn't matter whether you are a coach or not, all of you are welcome here. And I commend you for being here and engaging in this discussion. So what I did was I took each ICF core competency and aligned it with the trauma-informed competency. So for an example, competency number 1 is demonstrating ethical practice. But when we extend it towards trauma, we discuss demonstrates ethical practice as a trauma-informed reflective practitioner. So there are additional layers of competency that need to be plugged into ICF core competency framework as you operate within this space. So I explained this a little bit last time, and you notice that there's an additional competency being added because it cannot be put encompassed within the rest of the 8 ICF core competency framework. And those who might be new to this space, this did not come out of nowhere. I conducted a 2-year postgraduate research, academic research, in order to come up with this, and it's currently in the publication, and that's why it is not out yet. My publisher says that it's always better to have it confirmed there before I publish it. So please bear with me. But unofficially, during these sessions, I'll be sharing with you some of those, and I will do the first round today. Right. So continuing on, this is the part 1 of our lecture 2, how the unconscious whispers from the past quietly hold us back from our fullest capacity, potential, and our life. So in order to do that, so we are now diving in, the recap is done. Now we are diving into our exploration today. And one of you made a remark that that you appreciate if I manage the time. So I'll try and do that today. All right. So we continue on. So today we will start with foundational knowledge of trauma and trauma-related disorders. This is very important. We cannot talk about trauma if we don't have a foundational knowledge about trauma and trauma-related disorders. For an example, if you were to co-create with a clinician, in the clinic, I think in coaching, very often we tend to quite work individualistically with our clients, which is understandable. However, if you look at the clinical situations are often ecosystems. No therapist or no physician or a specialist, medical specialist would work with a client alone. If you simply think of like a surgery, you understand that we need a anesthesian, and then we need a surgeon, and we need several nurses specializing specific areas. So it's very common in clinical practices to work as an ecosystem with different clinicians coming together to support, help a client heal or a patient heal. Therefore, if you approached a clinician and want to work with them while the client is receiving clinical care, having the knowledge around trauma-related disorders help you to be able to seamlessly communicate with the clinicians, and you will feel seamless. You will feel very comfortable communicating because you have an awareness. So learning about trauma-related disorders do not necessarily imply that we will be crossing a clinical boundary. Rather, it helps us to remain within our boundaries and co-create, collaborate with other clinicians if necessary. In a seamless way. That's the reason why we learn about trauma-related disorders. So let's continue on. As I mentioned, here is a glimpse of the competency framework. Like I said, we are starting with the last one, 9th one, because it appears to be the most important one before we talk about anything else. So this is foundational knowledge of trauma and trauma-related, stressor-related disorders. And today we will discuss the first competency, which is, as you would imagine, this is quite a comprehensive framework. Therefore, within these 12 sessions, right, which will give me approximately about 18 hours to engage with you, as you would very well understand, I wouldn't be able to discuss each and every sub-competence, but I'll try my best to pick and choose the ones that would create a comprehensive understanding, and I will choose the ones that are most important, like I'm doing today. So the first competency under this framework is CTICC, is understanding trauma and stressor-related disorders. So trauma-related disorders is fueled by stress in many ways. So we call them in clinical terms stressor-related disorders. So the coach is knowledgeable about trauma-related disorders like ASD, so that is acute stress disorder, PTSD, post-traumatic stress disorder, and CPTSD, complex post-traumatic stress disorder. And so today's conversation is going to be grounded around these 3 disorders, and also further expand to understand certain limitations, certain potential of expansions, and so on. And also recognizing their potential impact within coaching, right? So this is how can coaching be impactful when the professional coach has knowledge about trauma, if not stressor related disorders? So that is what we are going to be doing. So if you are unsure, you certainly heard about PTSD, CPTSD, I believe. ASD might be new to you. I mean, you heard all of them. And you do know some similarities, differences between them, but you might not know clearly how to distinguish them. For an example, oh, what is PTSD exactly? What is the difference between PTSD and CPTSD? So that I will definitely be clarifying. So I guarantee you, as you walk away from this session, you will have this knowledge to a certain extent, just enough for you to be aware of this, right? Not enough for you to go out there and deliver trauma informed coaching. Like I said, this 18 hours is not adequate at all for one to position themselves as a trauma informed practitioner to a certain level. So you cannot necessarily identify yourself as a trauma informed practitioner after this lecture series, right? What you can say is that I have some awareness around trauma. I'm a professional coach with some awareness around trauma, not a trauma informed coach. For that, you need to have a technical qualification. Let's continue on. So we talk about stressor related conditions, right? Conditions and disorders. The reason why the two words being used, conditions and disorders. Conditions usually mean subclinical, which means that they do not qualify to be considered as a diagnosis. That means usually when psychotherapists work with um, clients and patients, when we make a diagnosis, it's important that there's a specific clinical criteria for us to say that this client has all of these symptoms, or many of it, or depending on the kind of context, that we can make a diagnosis. But there are many cases that's not the case. The client does not represent certain experiences and their world in a way that meets all the clinical criteria. So we call it subclinical. If not, they become stressor related conditions rather than disorder. So you understand, if it is a more towards a stressor related condition, there may be a possibility for you to work with them, having considered whether it is appropriate for you to work with your clients as such, right? So then let's look at three elements how stressor related conditions and disorders can start to show up in one's life. Stress, very often stress. So this is a normal response to challenges, usually temporarily and adaptive, which means can come back to the baseline, if not a regulated state, within a short period of time in a temporary situation. And the adversity is ongoing life difficulties that challenge our well being. And this is something that very often we see in our childhood. Many adversities happen to us, and sometimes also, of course, adolescents, adults, elderly people, adversities can show up in. So, adversity can be not meeting physiological needs, right? Like not having enough food, for an example. The right resources can be an adversity, which we could call as poverty, for an example. So adversities, which we will discuss more, and trauma we already discussed, right? So stress, adversity, and trauma can come together to create stressor related conditions or disorders. Now, a very simple one. If you attended my sessions, you have seen this before. Before we really go into this, I would like to invite you to recognize trauma responses. I will use the word trauma response quite a bit here in this session today, starting from today. Therefore, having some understanding of trauma response would be important. So this little boy had a traumatic experience, a dog attacking him. Maybe the dog didn't necessarily literally attack even, right? Maybe the dog was aggressively barking or trying to attack the child. And then when that happens, our brain, there are changes to our brain. So the neurological changes that can happen. So the nervous system change, the brain changes and the central nervous system. There are other parts of the brain and the nervous system can change. It also changes our body, and it also can even change DNA. And that's how the um, transgenerational trauma that happens, just like in the Holocaust survivors, that something changed in them, something changed in the cat, the wild cat. And then when the trigger is present, sometimes it is not necessarily rational to experience that fear, the re-experiencing that same fear. In this case, it's a pet dog and it's in a leash, so it's not necessarily dangerous. Nevertheless, this person, the boy, grown up to be an adult, still experiences some kind of a freeze response, a similar response that they had as a child. So we are starting to recognize the trauma response is some it's a specific representation of how we behave, feel, think, experience our reality when something makes us recall a traumatic experience. So we call it the trigger. And then the very interesting and the important thing that we need to keep in mind is that such trauma responses are often unconscious. Like I said in the last session, sometimes you lose your temper with someone and then you come home and go like, I'm not that person who lose temper with someone who might not even be responsible for that specific situation. But I still did, right? You were not conscious about that at the time, but you became conscious about that later time. And that's what we mean by unconscious responses. We respond, we react in a specific way, and later we realize that shouldn't have happened, right? This is a very simplistic way of explaining the trauma response. And please do not buy into just only this idea. In the next part two of this topic that we have begun today, I'm going to go very much in depth and show you many different types of trauma responses. And I believe if you do not have technical education around trauma, you probably would be surprised how much trauma responses are there and how much even the science hasn't captured it. So much research that still needs to happen. So some simple classic trauma responses: fight, flight, freeze. You hear this very often. Usually fight shows up as anger, irritability, aggression, disappointment. Flight shows up as anxiety, fear, panic, over worry. And freeze can be immobilization, disassociation, depression, isolation, compulsion. And then a quite uncommon trauma response, I think, is fawn: people pleasing, can't say no, prioritizing others, self harming behaviors. So, these are very simple, quick introduction to trauma responses. Like I said, in the next session, I'm going to spend the entire 90 minutes discussing about trauma responses. So, these are very simple, quick introduction for you to become aware of what are trauma responses and that they are unconscious. It's important for us to keep in mind. And that's really why very often you may have seen people saying, it's so obvious. It's that you shouldn't be angry or you shouldn't freeze. What? You are an old, grown old man. Why would you be scared of a puppy? It's easy for us to say. And the person also would say, yeah, you're right. But I don't know why, right? So it forms who we are. It kind of molds us to who we are. And very often it feels like a bad thing. Like I said, it's not necessarily a bad thing. It's because our body, mind, our genetics, even certain tissues in our body wants to safeguard us. Our body really loves us. Sometimes when we can't love ourselves, our body loves us so much. So that's why the trauma responses, it's telling us that there's something not balanced. There's something that can be regulated. That's what saying. So it's an indication for us to optimize ourselves, indication for us to heal ourselves, support ourselves. So it's a message, it's a loving, kind message from our body. The traumatic experience, unfortunately, regretfully, um, is not really a good experience. We agree. But at the same time, when we live in a reality like this, when we live in this gigantic blue planet, because we live in a hostile universe, hostile planet, we cannot necessarily always pursue pleasure only. We also need to have danger so that we know how to safeguard ourselves. Like, for an example, if you come to think of it, when a mother delivers a baby, that experience is traumatic to both mother and the child. There's really no a perpetrator coming to do something to the mother, coming to do something to the child. But you see that that kind of trauma is hardwired into our systems. It's our human experience, and that's what we talked about last time. So I invite all of you to not really, really to open your mind and recognize that trauma is ingrained as human experience. Without trauma, we will not be here. There won't be a planet. There will be a planet potentially, but there won't be beings, especially moving beings. Even plants can be traumatized. Even vibrationally, we can see that the plants can also recognize people who will harm the plant and can inform the using mycelium, the fungal networks, the root systems can even inform other trees that there is danger, there is potential trauma. How did the trees learn that? Through traumatic experiences, having trauma responses. So we are starting to recognize trauma is not something that we need to victimize yourself. Like for an example, one of the things professional coaches and psychotherapists who are trauma informed learn first is that we do not victimize the clients. We do not necessarily see it as a bad thing. So that also put us in a on a grounds that we can be well balanced when we approach our clients, and that does not affect us emotionally if we have that kind of a higher level understanding. So continuing on, so very often one of the quick response I get from sometimes people, those who might not know the work that we do well, is that, oh, you shouldn't talk about trauma. Trauma is not for coaching. Trauma is for like very big separation and almost like a bit of a fear. Understandable, it's because we are afraid of what we don't know. That's human behavior. That's how it works, right? So I want you to understand that when we talk about trauma response intensity, there's temporary, the acute stress that we talk about. So that is in the adaptive zone, right? So usually this is short-term stress response. Functioning remains stable, right? They can still function, they can go to school, they can go to work, and naturally resolves with time. And we'll discuss a little bit more. We will look at this a little bit more. And examples could be temporary anxiety, sleep disturbances, emotional overwhelm after a stressful experience. Maybe someone was in a car and the car met with an accident. No one was hurt, but the accident itself, the collision itself could be traumatic. So that is could be a temporary. I'm not saying that every car crash goes under temporary adaptive mode, right? There is no way of gauging which trauma is would impair, which can be high functioning or um, acute. There is no such thing. It depends on the person. One might be in the car accident, they will come out of it and then they will walk away like nothing happened. And nothing will happen ever about that situation except for that memory. But there may be someone else who might feel paralyzed, who might not be able to move. And it depends on that person's at the moment state of mind, the previous experiences, their body, their resistance to this kind of experiences, so many things. So we don't necessarily say which experience is temporary, which experience is impairing. We're just saying every human being will experience trauma in different ways. And then that would determine whether their responses are going to be in the adaptive zone, or whether they are going to be in a subclinical trauma response, or whether they will be in the clinical range. And the good news is that here, if they are in the temporary range, right, adaptive zone, and clearly see that the responses are short-lived, then you know that that's a space that a professional coach very well can work with the client. And then if you continue on, if we see a bit more intensity, you will notice that there are some subclinical trauma. Now, I mentioned what subclinical is. It might not meet necessarily the clinical criteria for a diagnosis, but they still will have certain difficulties and challenges. And why we use please note this word high functioning is not a clinical term. It's a term that we use to describe subclinical trauma. High functioning here indicates that you are able to function. There may be some difficulties, but the client or the person who experienced the survivor can function somehow. At the same time, they will also have challenges. So usually mild trauma related symptoms could be visible. Daily functioning remains intact, shows in stress. It shows up in relationships. It shows up when you are in a stressful situation. Like I said, we lose our temper sometimes, and that's the stress that is triggering us, right? And then sometimes relationships can trigger us very strongly when we are within the subclinical trauma response level, often not recognized as trauma. There is no clinical diagnosis as trauma. Usually psychotherapists, psychologists can assist clients like this supporting them to come to baseline faster, reprocessing things, and so on. At the same time, this is also a space where you can work with the client as a trauma informed coach, while a trauma informed therapist, a psychologist, is also providing the clinical care for the client in this case. So that's the co-creation I was talking about, the collaborative approach I was talking about. Why is that? Because the psychotherapist will go back in time with the client to that experience and enable the client to reprocess that, enable the client to reduce the intensity of the memory and the experiences. And a trauma therapist is specialized in doing so. You have the knowledge to recognize it, understand it. You also have the awareness and understanding of acute regulation techniques, maybe creating certain forward movement, post-traumatic growth. You could focus on the post-traumatic growth of the client, strategizing their post-traumatic growth. Usually you will see in high functioning subclinical trauma responses intensity, usually examples of this kind of responses would be perfectionism, overachievement, chronic busyness, people pleasing behavior, emotional suppression, and so on. In fact, one of my colleagues earlier asked about um, if we could discuss this for an example, right? So yes, here we are. Uh, she particularly asked if we can discuss about perfectionism. So here we are starting to discuss about perfectionism. And also in previous conversation, the lecture one, I also mentioned that certain things like perfectionism, imposter syndrome, mm, burnout, they can show up as subclinical trauma responses now, for an example, right? So you're starting to recognize how the trauma response, the intensity can change. And then impairment, clinical range. That means the criteria, the clinical criteria, the diagnostic criteria is met. So the psychotherapist, clinical psychologist will diagnose the client with the specific either ASD, PTSD, or CPTSD, or maybe other stressor related disorders. These are not the only stressor related disorders. I'm keeping it brief, provided the amount of time we have. So usually in this case, this is when one cannot show up at work, when one cannot focus at work, when one cannot get up, when one cannot sleep, or when one sleeps all the time, and when someone is depressed in some ways, when someone is experiencing anxiety. So these are also stressor related disorders as well, right? And then they have severe emotional dysregulation, which means that they can easily get angry, lose temper, involve in fights and things like that. And also they can't experience love, for an example. They can't experience peace, contentment, difficult, and difficulty in self-management. So some of them might not even brush their teeth, and some of them might not even dress up properly. They might not pay attention to their cleanliness, and so on. So these are some of the impairments, clear impairments. It's affecting their life in a way, social, interpersonal, intrapersonal, work-related, school-related, any kind of situation. And the examples can be severe anxiety or panic, disassociation, like not wanting to talk about the situation, and then emotional dysregulation and certain symptoms, and also instability in relationship and work. People with severe like PTSD, CPTSD often unable to maintain stable relationships as well. So you're starting to recognize that more we are becoming aware of trauma, the more we know our boundaries. We know when we would be able to work with a client, and when we should work in combination, and when we should not work with a client. So for an example, let me give an example of when we should not work with a client. So let's say because of the client's experiences, they have severe emotional dysregulation, they have disassociation. And one of the ways that this might show up as when they do self-referential thinking, when they think about themselves, they might become disorganized, they might become dysregulated, they might go into a panic, they might go into an anxiety. Why is that? It's because we have specific areas in our brain that process who we are, quite literally who we are, right? Basically, some parts are in the prefrontal cortex. So when this parts of the brain regions are activated, it somehow trigger the traumatic experience, or the trauma responses are starting to show up. So in coaching, what do? We invite the client into self-referential thinking. Why? Coaching is a process that enables the client to improve their autonomy, right? Clients' inner world, who they are. So when we are focusing on clients' inner world, when we invite the client to talk more about themselves, sense of self, what we do is we reactivate those areas of our brain. So when we do that, what happens is, instead of really inviting them to a place of healing and self-reflection, we end up triggering them. And this triggering can also be re-traumatizing to the client. So let's say if someone is in high functioning range or the impaired range, it's very important that client receives first clinical advice whether they are capable of receiving coaching. Only then you will be undertaking coaching. Even with clinically impaired clients, you still can work, but this cannot happen only with our own coach. It's very important that we first um, let the client see a clinician and then take their um, permission, supervision, and continue to receive the therapeutic care or even sometimes psychiatric care, and then continued coaching in terms of post-traumatic growth and acute regulation. If you are very new to psychology and this world, I would also like to clarify the difference between the psychologist and psychiatrist. So, as you are aware, a psychologist is someone who provides the therapeutic care, very often psychosomatic therapeutic care. A psychologist is not someone who is qualified to um, prescribe medication to clients. So, a psychologist is someone who will provide psychotherapeutic care, psychosomatic therapeutic care, body, mind related therapy. At the same time, psychiatrist is a medical doctor who has specialized in stressor related disorders, and they are capable of prescribing medicine. That's what we call a psychiatrist, right? So I hope that's clear in case if you're not aware. So now, of course, now that we are talking about trauma, it's important that we dive a little bit deeper and see what kind of trauma and adversities that we need to pay attention to. So I would like to share with you the Center for Disease Control and Prevention from the US came up with this 10 uh, ACE score, we call it Adverse Childhood Experiences, ACE, ACE, Adverse Childhood Experiences. So they came up with this key 10 criteria with a A score, which means if someone, how many of these adversities has one experienced in their life. Neglect can be emotional neglect, can be physical neglect, right? So that goes under immediately, you immediately remember Maslow's hierarchy of needs. So we have the bottom line is actually the physiological needs. Physical neglect can directly, like physical neglect can be the child is not receiving their meals in time, or the child is always out and about, and no parents or no caregiver is really taking making sure that the child is safe, for an example. So physical neglect immediately considered as trauma. Emotional neglect, maybe the parents there, maybe the parents are around, all the food is provided, there may be all the nannies, but they might not necessarily have the right nurturing care there. So you know that second layer is security. So emotional neglect lead to security needs, and the third layer is love and belonging. You immediately notice that then emotional neglect is also part of that. And then also if you notice the validation, right? Like self like affirming to ourselves, the validation, the next layer, and the final is the self-actualization. So you notice that some of these directly affect our basic needs. Basic needs are required for our survival. So if certain experiences are threatening our basic needs, you clearly see how it becomes an adversity and could translate as a trauma. Abuse, many forms of abuse, emotional abuse, physical abuse, sexual abuse. Like for an example, emotional abuse could be bullying, something as bullying. Physical abuse, sexual abuse is something that you're aware of. And also, I think I mentioned already, sexual abuse doesn't necessarily need to be that there was a sexual intercourse as such. It can also be maybe having exposed to a sexual some kind of sexual activity outside of the client, in this case, the child, or maybe maybe noticing infidelity, things like that. Sexual abuse can also be many different forms. It doesn't necessarily need to only be engagement, sexual engagement with the child in this case, or the person. And also there are so many household challenges that there can be, right? Mother treated violently, or mom being violent, substance abuse, mental illness in the household, an absent parent, uh, parental separation, divorce, someone being jailed, someone taken to custody, incarcerated household member. Then there can be many things, other things that can happen, which we will have another list that we will have a look very soon. So according to CDC, I would say it's still very limited operations, just 10 of these. I think it doesn't really do justice to this score, but nevertheless, just to create some kind of understanding, they were using this A score, right? Adverse Childhood Experience score. They wanted to learn if someone has been exposed to more than one or several ACEs, what would that mean at a later stage of their life in terms of their well-being. So the information that we found out is quite fascinating. I mentioned this last time, but today I have the information on the slide. So we found out that mental health disorders, behavioral effects, and the physical health issues among many individuals who have uh, a score of more than 4 tend to have these challenges. They can be usually depressive disorders, they can be substance abuse, maybe smoking, alcoholism, drug abuse, obesity, diabetes, heart disease, and the list goes on. Sleep apnea, stroke, and the list goes on. And then, as I have mentioned earlier, do you know that they found out that if one has experienced more than 6 ACEs in their lifetime, there is a potential that they would potentially reduce their life by 19 years. I rounded this up to 20. The results showed about 19 years. So you can imagine the kind of impact. In fact, we wouldn't even really know whether what is happening to us. So you're starting to recognize that the importance of being trauma informed, not just as professional coaches or psychotherapists or medical doctors or educators or leaders or executives. No, anyone, any human being need to be trauma informed. So trauma informed competency framework isn't just for coaches and psychotherapists. It's for everyone. I think in my personal belief, and many of you agree with me, that I think this education needs to start at a very early stage in school. So if you are an educator, if you are someone who is a policy maker, I hope this information will influence you in terms of how you continue to influence your environment. And that's also really why I am very passionate about this subject. I'm not just talking about this subject for us as coaches. I want to invite all of us to open our minds and recognize the kind of power that we could gain when we become trauma informed. Let us also look at some other prominent traumatic experiences. As these as these slides will become available to you, I believe that you will be able to easily continue your research on these specific types of complexities of trauma. For now, we look at a few, right? So sometimes we would not necessarily consider natural disaster as a trauma, like maybe the child is abroad and then the parents had a natural disaster. We might think that the parents really had the traumatic experience, but we might not consider the child. But in fact, the child might have different type of response to it, might be even stronger than the parents' response because of the uncertainty, because of not knowing what happened to the parents. Like imagine if the communication cut out for a while, right? So as a result of natural disaster, very different types of trauma can show up in the people of those who experience this. And then some of the things like sexual assault, we usually would say that would be like a straightforward type of trauma that people usually acknowledge, or being assaulted, maybe like a physical violation or physical fights or something like that. We also often say that, oh, this is trauma. But sometimes certain things like bullying, we might not see. It's like sometimes how nuanced it is in relationships. We don't even realize that sometimes our partner may be my partner may have certain bullying tendencies. We might notice this. We might have a coworker, we might have a colleague, we might have a neighbor who might have bullying tendencies. But acutely, like once it happens spontaneously, we might not think about it. But remember, prolonged exposure to this kind of adversities also can be can turn into traumatic experiences, then trauma responses, and then challenges in life as well. Moving on a few more. Racial and ethnic trauma. I am not sure if I could really know anyone who might not have racial and ethnic trauma. You'll be so surprised. Sometimes speak to people whom seem to be like uh, really the top of the pyramid, let's say like that, right? Like very often we look at certain nationalities, certain skin colors, certain eye colors, and we say, oh, they are really, they don't have any problems. Or let's say if I speak for myself, like being a brown-skinned person and coming from a developing country, and having exposed to global environment, I think sometimes I could feel, or people of my caliber would feel like, oh, I'm entitled to say that I have had racial and ethnic trauma. And what I have really come to learn is that even whom we consider as those who might have the privilege, right, some privileges, they also do experience trauma in very interesting ways. And very often we relocate ourselves, maybe with a child, maybe ourselves as a children. We have relocated several times. Very often we do not necessarily recognize this as relocation trauma. And in fact, today I was talking to one of my friends who is going through a transition like that. And then she told me, once I make this transition between the two countries, it would need me for about 2 years to settle down, to ground myself. And when she said that, I thought, what great awareness do you have? I'm not saying that she's going to experience relocation trauma, but she has an awareness of the kind of the intensity of relocation. But how many of us have considered relocation as a trauma? How about witnessing trauma? How about medical trauma? Like, for an example, giving birth to a child, or maybe going through a medical procedure. Very often, medical professionals are very much focused on how can we help this person physiologically, physical body, and we never even tend to ask about their mental, emotional, spiritual experiences, whether we really have been able to support them comprehensively. Because even, I mean, a medical doctor doesn't necessarily mean that they are mental, emotional, psychological trauma informed either. There was a time that recently we had two young people, very young people, coming from Germany. Both of them are medical doctors and friends. So we were driving, I was talking to them, and this is a medical student who is going through the last bit, and they are planning to specialize. So they were talking about this specific patient in the hospital who is a chain smoker, who is almost deteriorating right in front of their eyes. And based on what they said, uh, it's almost like they just only focused on their physiological addiction and gave up on this specific patient. In fact, this medical doctor even said something like, oh, you know what? He only has like few weeks. He will be gone. By the time probably we return from holiday, he will be gone. And I was shocked. I was absolutely shocked how they did not pay attention to where might that smoking addiction come from? What would that really, what is the depth of it? Can we help the client mentally, emotionally in a way that the person will be able to heal from their addiction, not just focusing on the physical dependency? So it's really very interesting. The world is not necessarily well trauma informed, and that's why we are doing all this work. That's why this is a session that I want to bring to you. Right, so there's a lot of types of trauma, right? I'm not going to discuss all of them, being mindful of your time. So feel free to go through some of these and see whether they make sense, right? So there are 4 pages of several different types of trauma, about 30, I believe. And for an example, let's talk about intergenerational trauma, right? If you recall, at the very beginning of the first session, I mentioned how my mom lost her father as he committed suicide, and how my mom went into many adversities and challenges, traumatic experiences, and assault. And then how that translated into her having many mental disorders. And then how that translated into our upbringing, me and my sister, and the challenges that we faced because of those challenges that we had, right? Intergenerational trauma. Most of the time, intergenerational trauma refers to from one generation to one generation, but it is not uncommon for it to be many generations as well. And that's intergenerational trauma. Usually, this is learned experience based on the impact of the traumatic experiences. And then you also have heard of the have heard the word of transgenerational trauma. Transgenerational trauma is usually when many generations, when traumatic experiences are passed on as trauma responses, sensitive to triggers over several generations. So, for an example, earlier we talked about Holocaust survivors and their children. Now, that's a great example of transgenerational trauma. Political trauma, so many different types of trauma, right? All right, so now we looked at many different types of trauma. Now we need to see how they translate into becoming a disorder. Becoming a disorder. So let's look at